person may have some alteration of consciousness. They may lose consciousness completely. They may have what are termed clonic movements. These are the rhythmic shaking movements that occur. And to the eye, it's very difficult to distinguish between epileptic seizures and episodes that are non-epileptic. Now, how do we distinguish between the two? Certainly, the description of the episodes is important because sometimes there are various features of the episode that helps us to understand if it's an epileptic seizure or maybe it's a non-epileptic seizure. But ultimately, reporting an episode on video EEG monitoring gives us the most information. There are specific changes that occur within the brain during an epileptic seizure. Think of a seizure as an electrical storm taking place within the brain. This electrical storm is able to be captured on the EEG. So when we do an EEG during an episode, during an epileptic episode, there are specific changes that we see. As opposed to when somebody's having a psychogenic non-epileptic seizure, when we do the EEG, we don't see the same types of changes. And that's really the important distinction. So recording an episode really gives us the most information. Now what tool do we use to record the brain's electrical activity? The EEG, the electroencephalogram. The electroencephalogram records the electrical activity over various regions of the scalp. The first goal of EEG monitoring is to distinguish episodes that are epileptic versus those that are psychogenic. We use electrodes over the surface of the scalp that record the brain's electrical activity, and most EEG labs will use about 20 electrodes that we place over the surface of the scalp to record the brain's electrical activity. We affix the electrodes to specific regions of the brain, and these are not placed haphazardly. The electrodes are placed on specific anatomic landmarks, so it doesn't matter where you have an EEG done. This electrode here in the front is always going to be in the same vicinity, and the physicians know the placement of this specific electrode, where it's sitting, and what brain tissue is underneath that electrode. And these are the various electrodes that are placed within the scalp, and they all have a specific name. For instance, F3, that stands for frontal. We have T for temporal, P for parietal, and O for occipital. These are specific landmarks in areas of the brain that we record the brain's electrical activity from. And often patients are brought into the hospital specifically for what's termed video EEG monitoring, where we monitor their electrical brain activity, sometimes for several days, in an attempt to capture an episode. Now, the output from these electrodes are recording the brain's electrical activity, and there are various types of patterns that we can see at baseline. So when a person's awake, there's a certain pattern that we see. When a person's sleeping, the patterns tend to be slower, much like the bottom half here. Now, when we put all those electrodes together, we get a reading like this. And this is your typical page of EEG. This is about 10 seconds of the EEG, and there seems to be a lot going on here. And a epileptologist or a neurologist is able to look at this and determine what's a normal pattern and what's an abnormal pattern. Now, video EEG monitoring has been around for a few years, but it really replaces what was called a routine EEG. A routine EEG would be a procedure done typically in the office, maybe a half hour, maybe 45 minutes, that recorded the electrical activity over that period of time. It's very limited in that we're not able to record episodes, which is very, very important. And also the baseline EEG, if there's an electrical abnormality, maybe an electrical abnormality occurs once every 2 hours, doing a 45-minute EEG could miss an electrical abnormality. The longer we record for, the greater chance of picking up one of these rare abnormalities. And also, the longer we record for, ultimately the hope is to record the episodes that are occurring, because that gives us the electrical signature of the episode to help us distinguish an epileptic seizure versus a psychogenic seizure. And there are various types of video EEG machines that we use throughout the hospital. Many of them are portable. We actually have what's called outpatient ambulatory EEG monitoring that we can use for monitoring at home. Patient comes to the office, we hook them up to EEG, pretty much the same technology that we would use in the hospital, and we would monitor the brain's electrical activity from home. And this can run for several days. Some of the newer systems also have a video camera, so we can see the episodes if they were to occur. We can go back and look at the video to see what the episodes look like. There are other various tests that we use in assessing patients. The brain MRI is a very important tool that we use. This is to look for any type of structural abnormality to the brain, which could be responsible for seizures. The MRIs nowadays are very high resolution, so we can see very, very small changes within the brain that otherwise may not be visible on things like a CAT scan. And most patients that are being evaluated for seizures have an MRI as part of their workup. We'll talk a little about psychogenic non-epileptic episodes. Now, what are psychogenic non-epileptic episodes? These are episodes that to the eye resemble epileptic seizures. Okay? Even physicians that specialize in treating various seizure disorders can have a very difficult time distinguishing between the two. Many times they're indistinguishable. And really the non-epileptic psychogenic seizures can mimic many different types of seizures. So it's not just a grand mal seizure. You can see other types of episodes that mimic other types of epilepsy. It's a very common condition. About 25% of the patients that are referred to us for video EEG monitoring because of intractable epilepsy, these are patients that have been treated for years and years and years with seizure medication for epilepsy, turn out to have these non-epileptic episodes. And it's extremely important to distinguish between the two because the treatment modalities are quite different. Okay? So if a patient's having psychogenic non-epileptic seizures and you're treating them with epileptic medications, it's probably not going to have much effect. Okay? So it's extremely important to distinguish between the two. And a very high percentage, 25% of patients that we see with intractable epilepsy turn out to have psychogenic non-epileptic seizures. Now, a good working definition, what are the reasons why people have these psychogenic non-epileptic seizures? We believe it to be somatic conversion disorder. So most commonly, this is what we see. And this is an unconscious production, unconscious, the person's not aware, not doing this willfully, an unconscious production of physical symptoms, so whether it's losing consciousness or becoming confused or shaking or stiffening, okay, due to psychological factors, okay? Unconscious, person's not aware, causing physical symptoms, okay, due to some sort of psychiatric or psychological condition or factor, okay? As we said, very difficult to distinguish clinically from the eye, and that's why we use the EEG. Some of the clues, treating these episodes as epilepsy, putting a patient on medications like Dilantin, phenobarbital, they're really not going to have any effect on these non-epileptic episodes. Okay? If they were epileptic, certainly you would want to treat with those medications. The non-epileptic seizures, seizure medication is really not going to be helpful. We look for emotional triggers, things that may bring on the seizure, stressful situations. Okay? Sometimes these can cause epileptic seizures as well, but sometimes there is a emotional trigger that brings on these episodes, but not always. We look for subtleties in the episode itself, and again, even an expert in the field can be fooled just by looking at the video, and that's why we rely heavily on the EEG monitoring. We look for what happens after the episode. Typically after an epileptic seizure, there's a prolonged period of confusion or lethargy, the person's very sleepy. While during the psychogenic episodes, the patients tend to come around much quicker. And there's unfortunately a lot of variation, so you can't really go by that entirely. But in general, with a grand mal seizure, patients have a prolonged, what we term post-ictal phase, while with the psychogenic episodes, patients tend to come around quicker. As we said, the psychogenic non-epileptic seizures can mimic many different types of seizures. And there are as many variations you can possibly think of that we see during a psychogenic non-epileptic episode. Right? So nothing is really off the table in terms of what could happen during one of these episodes in terms of clinical manifestations, whether it's shaking of one limb or shaking of all limbs, of periods of confusion, of speech difficulty, and all of these things can occur during a psychogenic non-epileptic seizure. Some of the things that we do look for in patients with psychogenic non-epileptic seizures is variable responsiveness. So typically, during an epileptic seizure, a person may be partially aware, and that can either progress to complete loss of consciousness, or the episode itself stops. During a non-epileptic episode, the episodes tend to have some variation. So a person may be initially confused, they may then become coherent and be able to respond, and then lapse back into periods of confusion. So there may be a waxing and waning of symptoms. Again, this can happen as well with epileptic seizures, but in general, patients with the psychogenic episodes tend to have more variability within each episode. Typically during an epileptic seizure, because of the strong electrical discharges that are occurring within the brain, you often get very symmetric type of movements in terms of the shaking and jerking. During a psychogenic non-epileptic episode, the motor response can be quite variable. So there may be one limb involved, it may switch to another limb. There may be more whole body shaking, there may be some head movements. There's a lot of variations that we see. The patients with epileptic seizures tend to have very stereotypic episodes, meaning that they have a specific pattern that is seen over and over again. The way the seizure begins, the way it evolves, the way it ends. Most patients have one type of seizure, and that's the type of seizure they will display. Some patients have many types of seizures, more than one type, so we have to be aware of that as well. But most patients tend to have the same type of stereotypic seizure. Patients with psychogenic non-epileptic seizures tend to have more variable episodes. So the episodes to the eye sometimes look one way, while another time they may look differently. Okay? And again, there's a lot of crossover. Some patients with psychogenic seizures have very stereotypic episodes. But in general, the epilepsy patients tend to have more stereotypic episodes. Now, one of the concerns in treating patients with psychogenic non-epileptic episodes, as we discussed, the treatment for either condition is quite different. We don't want to place a patient with psychogenic non-epileptic seizures on epileptic medication, and we don't want to have a patient with epilepsy not treated for their epilepsy. All right? So nailing the diagnosis is extremely important. Unfortunately, there's about 20% of patients that will have both. So we have a patient with psychogenic non-epileptic episodes. About 20% of them can have coexistent epileptic seizures. Okay? And it's very important to thoroughly get a good history and do the Eeg monitoring and attempt to determine what category they fall in. Do they have psychogenic non-epileptic episodes? Do they have epilepsy, or do they have a combination of both? Okay, so that's very important. Because 20% of the patients that we see have psychogenic non-epileptic episodes. 20% of those will have epilepsy as well. So it's very important to get the diagnosis correct. Patients with psychogenic non-epileptic episodes go on average 7 years being misdiagnosed or not treated for their condition. All right. These are patients that, unfortunately come to the emergency room, get put on seizure medication, maybe have a follow-up with a neurologist after a few months, may have a few more episodes in between, they're put on higher and higher doses of medication. At some point, a second medication or third medication is added to their regimen. They continue to have episodes treated as epilepsy when these medications are going to be completely ineffective. And these patients go many years without receiving the appropriate diagnosis and the appropriate treatment. Yes, sir.
Is it possible in cases where there's comorbidity that the medication for the epilepsy would somehow aggravate the PAS or make that worse for it?
Yeah, there are certainly types of epilepsy that can be aggravated by the wrong seizure medication. So when we're dealing with epilepsy, we need to know the type of epilepsy a person's having and get them on the right medication, because certain medications are completely ineffective for certain types of epilepsy, okay? Completely ineffective. And there are other medications that can actually make seizures worse, epileptic seizures worse. Now, in response to your question, most seizure medications are not going to aggravate a psychogenic seizure. Many of the seizure medications are also being used by psychiatrists these days for various mood disorders. So it could be that a patient gets put on a seizure medication for psychogenic non-epileptic seizures by accident and actually may have a positive response in the sense that it's helping to modulate some of the mood issues that are maybe fostering these non-epileptic episodes. Okay? So typically a seizure medication is not going to make a non-epileptic seizure worse. It's just, in most circumstances, not going to be at all helpful. There may be some positive mood stabilizing property to the seizure medication as an unintended effect, which may actually help the episodes. But there's certainly better ways to go about it than putting them on a seizure medication with some minor mood stabilizing properties. Yes, sir.
I'll have to look it up. There's a couple of studies that actually are out that actually state that the epilepsy meds can actually make the PDS worse. So I'll find that.
Yeah, if you could find,
yeah.
In general, in theory, because the conditions are quite different, you wouldn't expect that. But no, there's some new research that's come out to show that. Certainly like to see it. Any other questions? Now, because the psychogenic non-epileptic episodes typically do not respond to seizure medications, when patients come to the ER, they're exposed to high doses of typically sedative class medications. These medications can impair breathing, and it's not unusual for a person who's having psychogenic episodes to be given so much medication that they then require transfer to the ICU and put on ventilators. And about 50% of the patients with non-epileptic seizures, if left untreated, at some point in their history will have been to the ER and will have been given sedative medication and had to be temporarily placed on a ventilator until the medications can wear off. So sometimes the treatment, the incorrect treatment, there's certainly a lot of hazards inherent with that. That's it for my talk. Is there any other questions? Anything I can answer? Yes?
What can we do as a community to educate these doctors? Because I have been mistreated by several ER physicians and other doctors who don't know, instead of saying, I'm not familiar with this, let's find somebody else. They tell you, oh, there's nothing wrong with you, or I believe that these events are real to you,
Right.
or I don't understand why you're here, you just need to go home.
Right.
Well, what can we do to educate these doctors?
It's a very good point, because part of our medical education as physicians, especially as a neurology resident, this was a diagnosis that, as common as it turns out it was really not addressed adequately, and many physicians are not aware of the full implications of this disorder, and unfortunately, it's still common where patients are misdiagnosed or treated as an epilepsy. Thankfully, because of the various epilepsy centers around the country, where you have specialty groups that see a lot of these patients, so they've built up some expertise in treating them. And certainly we have many physicians here that work with our team who are very, very up to date on all the various treatment modalities and diagnosis of the psychogenic non-epileptic seizures. Yes, so unfortunately it is something that sort of had remained in the shadows for a while, but I think there's more and more awareness that's being developed. And many hospitals now have neurologists that specialize in epilepsy who are very aware of this psychogenic non-epileptic type of seizure pattern. Anything else? Yes?
I've been dealing with this for over 5 years, and actually it started probably at work. And I didn't even realize it was happening. Until one day I was actually on a telephone call with a client, and I could hear that client talking, but I couldn't respond to the client. But in that point in my life, I was the type of person who just kept on going and going and going. So I ignored it. I just saw a new neurologist last week, and I wasn't too satisfied with the results because of the fact that it was like they don't know how to treat it. And I'm separating what you guys are saying today to what I'm dealing with when I see a neurologist, when I see a psychiatrist for medication, when I see a therapist. I'm seeing all these doctors, but the main issue that I'm finding as you're talking is the financial part, or the part where the insurance companies aren't covering what we could get from you compared to going to a neurologist or going to a psychiatrist and therapist. I've been doing this, and it's becoming frustrating because of the fact that no one has answers. That's why I'm here today. But again, when you say that 7 years, I'm at 5+ now, and I'm still like nowhere as far as getting a resolution.
Hopefully with the lectures today, there's certainly a lot of professionals that are aware of this condition and that are actively involved in treating patients with this condition. That was not the case a few years ago. This is a condition that's been around for a very long time, but is now being recognized more and more and more. And hopefully with some of the lectures today, maybe some of the questions would be answered, and certainly to follow up with a group of physicians that is familiar with this condition, and that, in some cases, especially, we have, physicians and psychiatrists, psychologists that specialize in this condition, because it is so common, and for years was not recognized.
Okay.
Yes?
You talked about increasing awareness, but what are groups like yours and perhaps other comprehensive epilepsy centers doing to influence pre-service education for medical schools today, of the new batch of clinicians that are going out into the workforce? I'm wondering what kind of advocacy efforts are being done to influence increasing awareness on this. And I'm asking, I'm sorry, especially around coordination of care. And so, it's one thing to be diagnosed with this and then sort of be released into the world to say seek treatment, but then there's the other side of things as well, where coordination between the neurology side with the psych side.
Right, no, absolutely. So for instance,
and I'm pretty much saying the same thing that she's saying.
Right.
Where there's a communication gap. There's somewhere.
Absolutely. So for instance, I work a lot in the hospital, and we do the video Eeg Monitoring procedure. And I'll see a patient who's having recurrent episodes. Maybe episodes have been going on for quite some time. We do the EEG, we find out the episodes are psychogenic, non-epileptic episodes, okay? At that point, the interaction with the patient is critical, to explain to them fully what the episodes are, what's causing them, what the treatments in the future would be and what they shouldn't be, to make the patient fully understand what they're going through. Because for years they were probably being told they were having epileptic seizures, so this often comes as a big shock. Okay, that the treatments were ineffective, the diagnosis was off. All right, so we spend a lot of time in the hospital discussing this new diagnosis, and most importantly, what are we going to do as we move forward? And often we refer to the group that we have within our group, composed of the neuropsychologists, who have a lot of expertise in treating patients with this disorder and getting them the appropriate help from those physicians. That's who I rely on to help in managing these episodes as we move forward. In the hospital, it's important to diagnose and then to get the patient going in the right track. As for expanding awareness, certainly we do our part in terms of educating the various physicians, especially in the emergency room, to call the seizure doctors whenever there's a seizure patient that they're seeing, to discuss the case, and many times we'll bring the patient directly into the hospital to do the Eeg monitoring so we get the appropriate diagnosis as early as possible. And I think you're seeing more and more awareness that's occurring through the various advocacy groups. We have many people here that work with patients with psychogenic non-epileptic episodes. So I think you're going to see more and more of that. But you're right, for years this was something that was certainly not recognized, and there were very limited treatment options. Yes?
I think one of the things, I hope you agree, that I heard her say was getting it paid for.
Mm-hmm.
Because many of the clinicians, as I understand, who treat this, like therapists, are not in network, which can be a huge financial burden on the patient.
Sure.
Is that what you?
That's what I was gonna, yes, I was gonna bring it back up again as far as the not network, because that's some research that I'm gonna be doing this week.
You know, so how do you, I think one of the things she was advocating, how do you advocate for the insurance company? Now, I know when I had to certify somebody for disability, along with the disability papers they sent, I added all this information about PAES. But I don't think most clinicians are going to do that.
Did the insurance company recognize?
Actually, yes, and I did this about a month ago,
Okay.
and they authorized her out on disability until April 2017, which is pretty amazing. And then I got something shortly thereafter for all of my clinical notes, of course, because they don't want to pay.
Right, yeah.
You know, especially long-term disability.
Sure.
But I think, I mean, this is not advocating for myself, but I think most clinicians don't have the time to do it, nor do they have the information.
Well, I think a lot of physicians are simply not aware either, that they're not aware of this diagnosis, and, having physicians that, specialize in this, that know how to approach the insurance companies, know the various ICD coding for this, to get them, the appropriate services.
Well, the psychiatrist I sent this person to, who I hold in tremendous esteem, told her basically conversion disorder is an old diagnosis. I've been working with him for years. And, that's not true.
And especially, the treatments are very, very highly specialized and individualized. And, the neuropsychologists spend a lot of time with the patients to better understand what is bringing on these episodes and to come up with a clear treatment plan, not necessarily medication-based.
Well, I'm not a neuropsychologist, and I seem to be treating her successfully. And I'm also a fool who takes in-network insurance.
Yes, maybe as a follow-up, maybe something that could come out of this conference is some sort of resources that people can be pointed to, where there are ways to do this. Maybe somebody's kind of tried to has figured out like you have, that maybe there are, there are ways to go online or something.
Yeah, absolutely. I think Dr. Myers is going to, through the lectures today, that at various points there will be recommendations and references for various outreach. Yes, sir.
One of the options that a lot of patients may have, at least the route we went, was because we could not find anybody within so many mile radius that actually specialized in PNAS. So we actually had to go directly to the insurance company and let them know there is no specialist, so you get a one-off approval so that you can go out of network and still have to pay at the network rates.
That's a good point.
Well, that means you have to agree to the in-network rates.
That is true, but it
It's
also
no case agreement. I used to work for a managed care company.
right.
And it gets very complicated And the thing is, I mean, it's all about universal health care, but it's really a shame they have to go through that kind of appeal process.
Right. But the benefit with doing the in-network rate for the patient is
Single case agreement,
what's that?
the single case agreement.
Exactly, thank you. Is by doing so, at least it's the pay will be at 100%, just the 80%. So bring down the out of pocket costs for
So
them.
I agree, I just,
Yeah.
Well, I'm sorry, one more question in the back?
What happens if you are diagnosed with PMES and you happen not to have your home surrounding when you are having the seizure, and they take you to a hospital without you being aware? How, when you're in the middle of the seizure, can you prevent the hospital from giving you the seizure medications or the sedatives that you were suggesting? How do you advocate, I guess not advocate, how do you stop that, or
Yeah.
what do you do with that?
Yeah, I mean, one would be a bracelet with the diagnosis. You know, the physicians in the ER have to assume the worst in terms of a person coming in with an episode. They want to make sure that if it's an epileptic seizure, that the airway's intact. They want to try and suppress the seizure as quickly as possible. So without any knowledge ahead of time, the ER physician is going to follow a certain protocol. That's often been involved a lot of these sedative type medications. But things like having an alert bracelet or having a physician that is contacted right away, so the ER physician contacts the physician immediately as you're as you enter the emergency room. Your physician is contacted, who could relay to the ER physician what the diagnosis is, so they don't go down this treatment arm.
Right, so just putting a PNES, do you feel enough emergency room technicians would know what it is?
I mean, you know, it's a difficult situation. I think having a hospital that is your physicians are at may be helpful too, rather than going to a hospital that has never seen you before. Someplace where in the record maybe the ER physician could pull up and see that you've been treated for PNES in the past. Those types of things. Unfortunately, showing up at a ER where they don't know you, they're going to begin going down this treatment arm of treating it as an epileptic seizure and begin, the usual treatments with very sedative medications. All right, folks, thank you very much.
Thank you.